Hello there, this is Dr. Mintz. This is a patient who sustained a gunshot injury. Obviously, here you can see little particles of the bullet strewn along the path of the bullet and the bullet lodging somewhere near the midline. Of course, on a frontal view, we don't know if this is in front of the sternum or posterior to a spinous process or anywhere in between. Maybe a little evidence here though. If you look at the trachea is decidedly displaced at about that level. That to me suggests that there's something in the superior mediastinum that has affected the superior mediastinal soft tissues and produced this mass effect related to presumably a hematoma. If we look over here on the left, we see that there is pleural thickening. Of course, it's acute, so presumably it's pleural fluid. And since it's a gunshot injury, this is presumably a pneumothorax, blood in the pleural space. That means, and make sure you're clear on all of these basic things, that there is blood between the visceral pleura, which lines the outside of the lung, and the parietal pleura, which lines the inner aspect of the thoracic cavity. Now that may be obvious to you, but it's important for your understanding of the pathophysiology of a number of processes that you realize that this pleural space on this side is a potential space. It may contain 1, 2, 3, a few ml of fluid, but for the most part it's a potential space, and that's very important. What little bit there is in there, what little bit of fluid there is normally there, is just fluid and of course no air. Air would pose problems. On this side we have thickening there, so this is blood in the pleural space. How do I know it's not in the lung? Well, if it were in the lung, it would look something like this, because that is blood in the lung. And when you injure a lung, you can get a contusion, which is a direct non-lacerating blow that causes hemorrhage, and we see that in car accident victims. And you can also get a laceration. In this case, it appears to be both. Okay, let's look at the CT here. Alright, so here we are coming from the top down. Zoom in a little bit. Okay, coming from the top down, that's a once through. I like to do that, just kind of get a once through overview of what kind of problems am I going to be analyzing and how severe are they. So here we are going back up, and here we are coming back down. Okay. All right, let's take a look. What do we have? Well, first you want to know where the bullet entered. And we can see something of a trajectory. You see some bullet fragments here in the axilla. And this track of air in the left axillary region and this fragmented rib indicates this is the path. And then we have right here severe beam hardening artifact, which clearly reflects the large bullet fragment, the bulk of the bullet, that is lodged somewhere in relation to the spine. A little hard to tell for sure where. Let's see if I can window that. Metal is you can't window metal very well. But all right, well, that seems to have stopped shy of the canal. Of course, that's the big concern, spinal cord injury. Can't really see very much there, but on this level it looks like maybe it stopped at this part of the vertebra, which is the lamina. The lamina, maybe, hopefully for him. Okay, so that's what we've gleaned from this so far. So we have a trajectory which reveals opacification along the trajectory of the bullet. And you can see that things are kind of torn up in there too. Not a very technical term, but still clear. So the lung has been lacerated. It's been torn, of course, because this penetrating injury, a bullet, ripped through the lung. And the reason that there is opacification in the lung adjacent to that is a couple reasons. One, when you lacerate the lung, it bleeds, and it's going to bleed into the adjacent airspace. Secondly, if you have a rapid penetrating injury like this, there's going to be a contusional effect. There's going to be an impact. Of course, it's going to be a lot greater than that in the lung surrounding the trajectory of the bullet. And that will cause hemorrhage in that tissue as well. So I presume this is a combination of those two aspects. Aha, I see something else very interesting here. Okay. What else is going on? So we have a laceration of the lung, we have adjacent pulmonary contusion, of course, we have some fractured ribs and maybe, probably not a cord injury, but it's possible because if it landed at the side of that lamina and there was enough force at that time, there could have been a transmitted force that caused the contusion of the spinal cord. Okay, let's take a look here a little bit more. What else do we have here on the left? What is that? What space is it in? So remember, you always want to be able to describe things in terms of what it looks like and what anatomic area is involved. So this is not in the lung, of course, it's in the pleural space. And the pleural space, when filled with fluid, typically fills in this manner. We know it's got to be blood because we know the history. Let's see if I can get a measurement of the attenuation there. 46, so blood is usually 30, 35 at least, and often higher. So 46 is clearly blood and definitely not just a serous fluid. Okay, and let's see what else we have going on here. So you have contusion. What is this thing right here? What have we got going on? There's something there. Is that real? It could be. Let's see. Maybe that's part of the left lower lobe, and there may be some atelectasis in that. Maybe we'll see that more clearly on another plane. Let's see here. Well, there certainly is some atelectasis here in the left lower lobe, and that probably reflects compressive atelectasis secondary to pneumothorax. The blood in the pleural space is pushing against the adjacent lung. Now let's go on the right side here. Looks good. A little bit of this is what mild atelectasis, mild plate atelectasis looks like. He's probably not ventilating too well, not able to take good inspirations because of all the trauma on the left side and the associated pain. Now we're getting over to the left side. So here now we see that this pleural fluid, of course, is posterior, and we can see what looks like it is the major fissure. It appears to course in this direction. And so you have a contusion with laceration in the left upper lobe, and the left lower lobe appears to be affected by compressive atelectasis related to the pneumothorax on the left. Okay, let me put that in another window for you. Always want to worry about vascular structures. Obviously, some vascular structure has been injured here in order to produce that large pneumothorax, but always have to look carefully for things like aortic injury, pulmonary arterial injury, and active extravasation of contrast. What is that? Well, that means that when the contrast was given, if the patient was actively bleeding, you will actually see that contrast opacified blood pouring out somewhere. So it's worth taking a look after you've determined what I've just gone through and say, is there active contrast extravasation? Very important, and it really requires an additional specific look for that. So you look at it as I just did, and there's pleural fluid, obviously pneumothorax, laceration, contusion, Then you ask, is there active contrast extravasation? And that requires a very focused evaluation of all images to see if there is such active bleeding. And I do not see it here. These look like little tiny fragments, perhaps, of bullet, but they're not as dense as I would expect bullet to be, as in this case. So, they may be active contrast extravasation, little bits of active bleeding, but I don't see that the injury occurred there. So, I think that they look like they're intravascular, and therefore they're not actually contrast extravasations. Okay, so this patient was brought in and put right, and obviously had an injury, and put right on the CT scanner, and they did a CT and made the findings that we just noted. The patient then had a chest tube placed. Of course, you want to get that hemothorax resolved, because if you look, you kind of get a sense, you can see that this little movement, this displacement of the trachea that I mentioned, is not actually because of a focal hematoma here. It's the overall mass effect in the left hemithorax that's shifting the mediastinal structures to the right. So this is a hemothorax with mediastinal shift, and that's very significant. When you start pushing the mediastinum around, you're looking for trouble, because remember, the mediastinum is attached by vascular structures to the heart and to, let's say, the liver, from the IVC coming through the liver to the right atrium, and then the superior vena cava coming down, and of course other arterial structures as well. But the venous structures are more prone to being affected, compressed, occluded, when you start pushing the mediastinum around like this. Also, the mediastinum is more tethered posteriorly. So if you start pushing it, let's say in this case from the left side, it doesn't just move over this way, it kind of turns like that too. So they put in a chest tube, drained the blood out, then they got a chest radiograph because he seemed to be even more uncomfortable. What is going on here? What happened? Okay. Remember, first thing is to not get excited and try to say, what happened, what's going on, what do I need to say? Make objective findings and just list them. And the best thing you could do is you could write them down as individual findings. You speak them out to whoever is asking the question. But in short, what we have is, this is the mediastinum. You can see that it is displaced to the right. I think more so than before, because how much of it is actually projecting to the left of the spinal column? Almost nothing. And we already know that this area of opacity in the left upper lobe is the area of laceration with associated pulmonary contusion. This image also gives you a sense of just what I was saying of the rotation. So the mediastinum got pushed over, and when it couldn't get pushed over any further, it started rotating a little bit like this because of pressure on the left side. But they got the blood out. There is no hemothorax to speak of here. I think they've done a good job at evacuating the blood out of the pleural space. I don't see it there, but what's causing the pressure? Correct. It is a pneumothorax, but not just your average garden variety pneumothorax. This is producing pressure, and specifically enough pressure to significantly affect the location of the mediastinum. So this is a tension pneumothorax. Tension pneumothorax. Very significant, because this is compromising venous return to the heart, and it's further, when it's this severe, it's further compromising the ability of the ventricles to fully relax and fill as much as they need to. So you're limiting how much blood gets to the heart, and you're limiting how well the heart can contract. This is why a tension pneumothorax is an emergency, and our expectation in this program is that when you look at this, you should make the call, you should bring it to the attention of a radiologist and say, I think there's a tension pneumothorax here. That is one life and death matter that you can help the patient a great deal with. Tension pneumothorax. Okay, look at the bullet there. It's kind of in the middle of the left chest. Where was it here on the... It was up here. Okay, remember we saw it was next to the spinal column, next to that vertebra. So what does it tell us? That it was located here on the initial image, and then it's moved out farther laterally. It tells me that this is actually in the pleural space. There is no soft tissue structure in which it might have been embedded, that it could have so freely moved from its initial location out here. So it's somewhat of a relief to know that it is in the pleural space, and since it is, there may be a reasonable chance that there has not been significant spinal cord or vertebral injury. So this is tension pneumothorax. Let's look at it with that in mind here. Okay, you see the bullets? The bullet fragments, rather. Okay. So this is all blood in the pleural space. That is hemothorax. Just like pneumothorax is rather air in the pleural space. So even though it's the word thorax is used as if it's anywhere in the left side of the thorax, pneumothorax means air in the pleural space. Hemothorax means blood in the pleural space. Hydrothorax means watery fluid in the pleural space. Okay, we look at the vessels, make sure that the aorta particularly is intact. Main pulmonary arteries, left and right pulmonary arteries look intact, no active bleeding there. And if you look, the heart looks kind of small, but it's a fit, rather young person, so that may be normal for this patient at this point. But remember, this is before that tension has developed. Here you can see the chambers of the heart, left ventricle, right ventricle. And here's the left atrium receiving its return of oxygenated blood from both lungs. So remember, the ventricles have a more muscular, thick coating or wall. The atria have very thin, flimsy, easily deformable walls. So now picture this chamber here, the left atrium, and remember that is filling from the IVC here, upper abdomen. We follow that up, and that IVC empties into, the right atrium. The pulmonary veins empty into the left atrium, and you can imagine well that displacement of the mediastinum, if you take this structure there and you move it over to the right side, this soft, deformable wall of the left atrium that's right up against bone could easily be deformed. So it's going off this way, and if you imagine the mediastinum moving this way and additionally rotating, the apex rotating a little bit like this, then you're pushing this left atrium against the vertebra, and you're going to severely impair its ability to fill with blood. And likewise, from a superior approach, you have the aortic arch, and here you have the SVC. And the SVC empties into the right atrium. Of course, it's going to the right atrium because it's systemic venous return, meaning it has already oxygenated the tissues of the body from which it came, and it needs to be reoxygenated, and so it goes in the right atrium, then to the right ventricle, and then out the main pulmonary artery. and then to both lungs. So, a nice depiction of normal anatomy and some interesting pathologic findings related to a gunshot injury.